that is going to be a just very short half-hour webinar information session on particular policies, on particular discussions that we're going to share throughout the year. And I've got the pleasure to start off and do the first one. So my name's Professor Joanne Harris. I'm the new Dean of Medicine here at the University of East London, and here to set up a new medical school, a GMC accredited medical school that we're hoping to allow students to join from 2027. So I'm talking about the four-year undergraduate medical curriculum because that is linked to some of the work that I was doing in my previous role at the University of Buckingham, where we worked with NHS England to develop a prototype undergraduate medical curriculum. So I'm not going to detail the actual curriculum and what the things we came up with, but I do want to explore in this meeting something that I think may be of more interest, which is the stakeholder concerns we had as we were doing that work, and then how we address those. So as part of this, there'll be the basic principles that underlie that prototype curriculum. So I'm planning to speak for about 20 minutes, maybe a bit less, and then give you a chance to ask any questions that you may have. So where did this work come from? So it came from June of 2023, the NHS long-term workforce plan under the previous government now, and that will be relevant as I will explain. But those of you that were around at the time will remember there were quite bold proposals to double the number of medical students from 7,500 to some 15,000 by 2031-32. And also to enable schools to move from a 5 or 6 year medical programme, 6 years where they do the intercalated BSc, to a 4-year medical programme. And the wording of that document was that students undertaking shorter medical degrees would make up the substantial proportion of the overall number of medical students. And this was different to the 4-year graduate entry courses that are already functioning very successfully within the UK. So what do we do? So NHS England put out a tender for a bid to do this work, to develop this prototype 4-year undergraduate curriculum, and that was won by the University of Buckingham, where I was the previous dean. We were, however, interested in a collaborative approach from the start of this. So we asked for expressions of interest from other medical schools, and I'm pleased to say that some of my colleagues on this call joined those groups because the University of East London was interested also in developing a 4-year undergraduate curriculum, and I'll go into that in more detail. We were linked with NHS England to an early adopters group that they had at the time. There were 2 or 3 schools around the country in England who were keen to explore this and maybe be part of a pilot group to as early adopters to develop this 4-year curriculum. And our aim was to develop a prototype, so it wasn't the set curriculum, but it was a curriculum that other people could develop and take themselves and adapt to their own curriculum. And there was a toolbox of resources to enable people to do that. And during the course of this work, we involved probably more than 70 educators, both in the UK and abroad, and students as well, all from approximately 8 schools of medicine. So I've mentioned stakeholder concerns. So as we started doing this work, and even before we started doing this work, schools from the Medical Schools Council meetings we went to, these were some of the concerns that were coming up about even thinking about a 4-year curriculum. So there was the case of, well, what are you going to lose? How are you going to squeeze 5 years into 4 years? There was a lot of worry that the widening participation students would be disadvantaged by this shorter curriculum because they needed more time to get through the curriculum. There was concern that how would we support well-being? Students are struggling even on our 5-year curriculums, maybe with increasing mental health, adverse mental health. How could we support them? A lot of discussion about clinical placements that were felt to not be functioning very well at the moment. So how would we, with these 15,000 students going through accelerated curricula, how would we manage all these students on clinical placements? There was worry from the Medical Schools Council that the clinical academics, the future educators and researchers who are developed at medical school, how would the shorter curriculum allow them to follow these pathways? Lots of talk about financial impact, both for the students and for the medical schools themselves, and a discussion about whether any changes would be made to the foundation year in order to navigate this. So we followed various phases for this work, and phase one was really the equivalent of a literature review. So we looked at where this was being done elsewhere in the world, and there were some examples from Australia, where Bond has a 4.5-year medical curriculum. I should say as well that Buckingham, as an independent medical school, also has a 4.5-year medical curriculum. It mostly achieves that by a January start and by not having the long summer holidays. So the amount of teaching hours probably are very similar to the 5-year curricula. So we looked at other published curricula, other curricula that were shared. We looked at graduate entry curricula that are very similar to this. And we added this into the themes for our working groups, who were the teams that actually did the work, looking to incorporate some ideas into the design. We did a stakeholder consultation, so we asked quite widely what people thought about the idea of a 4-year curriculum, and generally people were quite interested. They wanted to know more. They expressed some concerns about what it might involve, but people were interested to hear how this could be achieved. So then we moved into the working part of this project. So we had a steering group and we had a core working group overseeing the project. And under that, we had these 6 working groups: curriculum, assessment, portfolio learning, clinical placements, technology, and student experience. Each of these groups was led by somebody not from the University of Buckingham to give that wide and differing views, making sure we had views of all our stakeholders. And these groups, we had quite a tight time scale, as often the case with these projects. I think we had 6 to 8 weeks for these groups to explore what they thought should be based or could be based within their area with a shortened 4-year curriculum. So I'm going to move to some of the stakeholder questions now, and particularly then how we address those in the work we did. So what is being lost? So this was said a number of times, and our answer to this, and we spoke at a number of stakeholder groups, the clinical academics group, the BMA group, a lot of people were interested to hear, but was that we weren't going to actually just take bits out of a curriculum, but it was rethinking the curriculum from the start. It was thinking about what students needed to know to be doctors. So the curriculum hasn't really changed since Flexner changed the curriculum in 1910 and brought it into universities. So although curricula talk about preclinical and clinical and integrating that and having early clinical experience, the curriculum is still broadly the same, with a lot being added to it. And people talk about the overcrowded curriculum. They talk about the carousel of curricular reform, where you talk about saying you're going to change the curriculum, but in fact you're just really moving things around. And we know that students now learn differently. Everyone learns differently. We don't need to memorize large amounts of information. We have that information available at our fingertips in the cloud. Doctors, as they work, don't need to remember all the details of the drugs and doses. That there's an app that will do that for them. So we need to work differently, and so we need to teach differently. And the GMC outcomes for graduates has looked at this in terms of one of the outcomes that I often point out to students, which is the need to deal with complexity and uncertainty. So healthcare is not certain. Things don't happen in an organised way, and we need to teach students some of those grey areas, some of the differences that can happen as healthcare is being delivered. We were very keen that we wanted to maintain science in the curriculum. This wasn't cutting things out, but it would be more the scientific principles rather than the factual knowledge. And we wouldn't be asking them to regurgitate that factual knowledge in an assessment. We wanted to teach the students to analyse the information that they could then apply to different situations, so be able to deal with that complexity and uncertainty. And I've already mentioned the assessments. How do we assure widening participation? So this had a lot of conflicting views wherever we spoke. So some people said that the students in their school were taking 2 jobs to even fund their time at medical school, and how could they possibly carry on doing those jobs in this shorter course? Others were saying that students would prefer a shorter course as they'd graduate with less debt. Students who are choosing to live at home because they can't afford to live away. So it was difficult. There was a lot of conflicting views about this. I have to say, one of the things we had to say was that although we had developed a 4-year prototype, it wasn't necessarily more intense in its time. I think we'd come up with 36 weeks a year of teaching in the prototype, and so there would be time for students to do their jobs in the evenings and weekends if that was important to them to fund their way. But also we were talking about how we would access this course, how we would look at contextual admissions, how we could choose the students we brought onto the course with an aim to be flexible, knowing that not all students will be able to progress through the course at the same rate. We'd need to have enhanced student support for students from a widening participation background and mentor those students, maybe with students from prior years. So there was a number of ways of looking at how this course would be suitable for that group. We were aware that we would need to support students, widening participation students and students who are doing a different type of course. So everyone is aware of the increasing levels of adverse mental health outcomes. There is some data in this in the BMA from Wilkinson, BMJ, sorry, quite recently. Students often afraid to talk about their mental health to the medical school because they're worried about being stigmatized. They're worried they'll go to fitness to practice, and we need to break that down. These are levels of depression and anxiety prevalence. In fact, this is from an American paper, but no reason that it's any different here. So really quite high levels amongst medical students of depression and anxiety, and worries that this shorter course would only lead to greater stress. However, what we were trying to say was that this a shorter normal course may cause that, but our course would be different in the sense that we would want to empower students with skills to manage their own well-being. So there was an idea that we would embed lifestyle medicine into the whole curriculum and encourage students to understand their own stress, their own nutrition needs, their own need for sleep, and a balanced lifestyle, together with the science that underlies that, and then show them how they could apply that to themselves, and then how they could apply that to the patients, their own patients, having a deeper empathy for what that involves. And there's a sense that already at the University of East London that we do that. We have the mental wealth courses that are already part of all the courses at University of East London, looking at exactly this issue. How are we going to support learning for students on this extended course? So I've already mentioned that students learn differently, that we're aware that they are using different skills, having different levels of different amounts of time that they want to spend on learning. Students are less likely to want to come and sit in lectures. They maybe want to learn themselves. And we wanted to increase students' autonomy and self-development time to have more flexibility over learning. So I don't know if you can see this pyramid on the right there. At the bottom level, you have pedagogy. So that's where you just deliver the teaching to the students. The next one up, the pink one, is andragogy, where you're teaching in combination with the students. But we wanted to move to hoitagogy, which is a learning theory which places greater emphasis on the learner's agency, on their own ability to do their own learning as they go through. And we were going to increase the amount of near-peer teaching from teaching fellows on the course and teach students humanistic skills. So this is not just communication skills or empathy, but ability to actually really understand, to have cultural awareness and understand their own responses to how they're responding to patients, to enable them to learn better, to enhance their learning on the course. Clinical placements. So there was a lot of talk about what do we even mean by clinical placement. So we know students spend a lot of time just hanging around in clinical placements, waiting for something to happen. It's sometimes called structured mooching, that they wait for the ward round, or they wait to go and see a patient, but the patient gets taken to X-ray. It's sometimes very difficult in these service-led areas. So we wanted to champion having more AR and VR in the teaching, more artificial intelligence, and more experiential learning, a chance for students to work as healthcare assistants or work within care homes possibly. So they're actually doing part of the job as they do this. And I've already mentioned the near-peer teaching from the teaching fellows while they're doing this simulation and while they're on the wards. So clinical academics was something, as I mentioned, that really worried people. However, a shorter course doesn't necessarily mean that you're going to have fewer clinical academics. So a lot of people will develop that side of their learning after they've left medical school. But even during medical school, we could foster a culture of continuous lifelong learning. So we would want to teach our students to teach and become health advocates in the community. So helping to, some of the public health skills. And the curriculum would be research informed to embed critical thinking. So we teach students these basic and generic research skills and allow them to follow that through in practice in parts of the course, teaching them about research frameworks in clinical, the clinical world, so they're aware of what is available. Foundation was a discussion. So during COVID, there was an FIY1 that you might know about, where students graduated early and were paid as foundation doctors. And there was talk at one stage of whether an extended assistantship could articulate with this shorter course. Unfortunately, we were told NHS England had no plans to do that, and preference informed allocation is very limited because students are unable to remain close to their medical schools. So some of the widening participation initiatives perhaps mean the students will then be spread around the country. So that's still under discussion. Financial impacts, again, there were lots of questions that we weren't able to answer at University of Buckingham. They were questions for NHS England. So would the medical schools receive less funding because 4 years of rather than 5? So it is less per student than you would have for normal courses, but then you might be able to increase your number of students if you could send them through the course more quickly. There was a lot of discussion about the OFS funding and the NHS bursary that we weren't able to answer. There was a lot of discussion about will it be a 1 + 3 years, like the graduate entry course, where it's 1 preclinical year and 3 clinical years, or will it be a 2 + 2, because that will impact on the funding. Again, and a lot of this wasn't clear, although NHS England did say that a course where students were taught on simulation, maybe by teaching fellows, would count for clinical funding. And this is where we got to really by the end of our 4-year curriculum work. So we handed over that prototype to NHS England, and they had hoped to run pilots in 2026, but as you all know, we had a change of government and it's sort of been put on hold. So we're not quite sure where it is. The government, West Streeting, is planning to make an announcement in the spring and summer for the long-term plan, the 10-year plan, I think it's now been renamed as. Not sure what's happening to the idea of increased numbers or shorter courses. University of East London hopes to run a 4-year medical course, and we would have an access course to that, which would be a level 3 course to add on to that. But it's unsure at the moment of where that's actually going. So just in summary, some of the principles that we wanted to put into this. So we were going to integrate lifestyle medicine, teach students humanistic skills to equip them for the future. We were aiming for capabilities rather than competency. So capabilities are transferable. It's not just, can I put in this cannula, but what have I learned during that to allow me to do something else? We wanted to encourage student autonomy, integrate more technology, allow students to actually do things on the job as experiential learning, and instill lifelong learning from near peer teachers. So that's the end of my presentation. And that was exactly 20 minutes. And I'll stop sharing, but are there any questions at all from anybody? Heather.
Thank you very much, Jo. That was really interesting. How did Bond University or the Bond University course go, the 4.5-year course? How have they been? Has it been going for a while, and is it accepted in Australia well? Is it integrated well?
Yeah, thank you. Really good question. It has. It's quite long term. It's not a new thing, and we spoke to somebody from Bond, actually. We had a contact there, so we spoke to them, and it had been very well accepted within Australia. Australia is slightly different because it has a lot of graduate entry medicine rather than undergraduate entry medicine. So, and this was talked about often on the course. So I think that Bond course is a graduate entry course, and the oh no, sorry, the Bond is an undergraduate, but there are lots of graduate entry, and people said, well, it's fine to do this for graduates, but how can you expect undergraduates to go through a course of this type? But the Bond course was very well received and had good feedback. And as I say, that's a 4.5-year rather than a 4-year. The plans for this were that it would have a September start because it was very fixed with the medical licensing assessment. So it couldn't, the timings are quite fixed. And we were very clear that whatever we taught the students, they would have to have the skills to pass the MLA as whatever was done. Najib.
Yeah, thanks. That was really interesting. I had a question around virtual reality and AI and how we can utilize that to deliver the 4-year curriculum. I guess the question is, how mature is that? How far developed is that? And are we ready to start using that now, or is that still some way off in the distance?
So yeah, thank you for that question. Again, I think we're ready to use it now. So we have recently had a presentation and we're about to purchase new equipment at the University of East London. I don't know if you've been to our campus, but we have a hospital, primary care and hospital healthcare hub kitted out. Have you been?
I have, yes, and I was quite impressed actually.
Excellent. So we've got the buildings. Now we need to work out how we're putting in the VR and AR into that. And we've had talks from, I thought this was really quite amazing. Using Google Glass, using a visual camera where a GP can speak to a patient, and there is a room full of students, maybe a distant site, all distant sites on a screen, like you're all on a screen now. The GP also has equipment that is connected in, so that the GP can speak to the patient and the students can see what the GP is looking at as they're examining. The students can ask that patient questions. And then, for example, the otoscope is wired in. So when the GP looks into the student's ear, the students can see what the GP is seeing through that otoscope. So I thought that, and that's current and something that we're actually looking to purchase at the university as a pilot to start very soon. So I think there is a lot of this that is becoming more and more common. The other thing we do here already is the Oxford medical system, where we have avatars, and that's getting better all the time, where students can ask patients questions and can make decisions about what treatment to use next. And it's a learning system. So if you, for example, give the wrong drug, then you know there's an adverse event with the patient, and then you may need to, something else goes wrong. If you give the right drug, something else happens. So it's a system that actually learns and is very flexible within that, and they're increasing the number of systems they have, and the ability for that patient to answer questions from the student is increasing as again with AI, as you would expect, as those patients learn more about the medical interview. So I hope that helps answer your question. But I think, yes, it's all going to improve, but I think we're ready now.
That sounds all really quite exciting. It'll be wonderful once we've got the system in and running. Perhaps we could come down and actually have a look at it and test it out. I think just from
Absolutely.
an educator point of view, it would be really nice and reassuring for me to see what it actually is like. I've heard a lot about it. Now I want to see it in real life.
Absolutely. And in the process of our discussions, we're also looking for a pilot general practice that might want to have, I don't know if you're a teaching practice, that might want to host some equipment or try this out. So if you're interested, then contact me afterwards.
I will drop you an email because that sounds like it's quite a good opportunity. So yes, thank you for that.
Thank you. Rupa.
Hi, Jo.
Hello again. Hello.
Thank you very much. It was a really lovely presentation. I just managed to listen in on driving between two meetings, so thank you. I love the idea of AI and all these technologies to essentially reduce idle time, which you mentioned during your presentation. At the moment, I do a lot of teaching at King's, so GKT Medical School, and one of the big themes are they stand around doing nothing for a considerable, worrying amount of time. So I don't think necessarily having a shorter course, I know you're calling it 4 years, but it's actually more like 4.5 years, is really going to cut much out if we can be efficient. I had 2 points, one about maturity of students and the second one about clinical humanities. So first one, if students are going to be graduating potentially sort of 2 years earlier than somebody doing a 5 or 6 year course, have we sort of done a risk assessment on that and how that is? Because if they enter university at medical school at 18 and they're finishing in 4 years, I do feel that that is a factor in terms of their brain maturity, because we're not really fully developed until we're around about 25. So how are we going to support them in doing that? That's a little bit of a concern of mine. So I already feel that maybe it should be a postgraduate degree anyway. So just how we'd mitigate that. And the second one was, we've been doing some clinical humanities teaching at GKT, and it's really beautifully being received in terms of what you mentioned in regards to complexity and contextually approaching clinical care and patient interactions. So they did half the year last year, and from this year every student at GKT are now doing the clinical humanities project, and I've just started teaching on it, and I was wondering how that would fit into us at UEL.
Thank you. Yep. So I'll take this in turn. So maturity, yes. I mean, I have to say, I'm not sure maturity is a number, and I think it's something, isn't it, that students have and can develop, and we are talking about an access to medical school. So it may be that this isn't for every student, and something that was talked about is do you have different entry points to your course, so that some students could come straight into the 4-year and some would come into an access course where they would develop some professional skills and develop that maturity. So I'm not particularly worried about the number or the age they are, but yes, what have they been allowed to do on the course that will help them develop that maturity? And I think it's important. Difficult to risk assess before it's tried as a pilot, and it is recognized that a lot of support would need to go in to that. Absolutely. The second part about clinical humanities, yeah, absolutely. I was at Imperial before I was at Buckingham in my previous life, and we had a lot of medical humanities there. It was a very big department. I remember taking students to the V&A Museum to look at the statues and learn some of their dermatology and some of to get actually hands-on to feel things. So I think that's a brilliant idea, and definitely something that we'd like to incorporate.
Thank you. Thanks.
Heather.
Following on from what you said about the years not being able to start in January, why is that? Because one of the things that if this, I mean, even if there's going to be an expansion, there's going to need to be some moving around of term times and using of the summer breaks. Why exactly isn't there any flexibility on that? And how's Buckingham got around that problem?
So that's a good point. So, but Buckingham starts in January, and then students take the MLA 4 years later. I think it was in order to allow some time after the MLA, so they could do assistantships and things of that nature. That's a really good point, actually. I need to take that away and have a think about why that didn't work. And I was just something that I was perhaps told and accepted uncritically. So we didn't really get into a timetable or mapping it out in that sense in terms of the prototype course, because it was very much going to be something for other people to adapt to their own. But yes, perhaps it is possible and needs to be looked at. So actually we've reached 1:30, so I'm going to end there. Thank you very much for your questions. Thank you for your time. Happy to answer anything later. I'm just looking in the chat in case anything was in the chat. Thank you very much, and I look forward to meeting you all very soon.